sternal notch, anterior border of the sternum there. You come down a little bit below that and off to the side, well, that's your second rib. And you go down just below that, and that's called the second intercostal space for between the ribs. Well, that happens to be where the base of the heart is, and the second intercostal space. And you can follow the sternum down, and you get the xiphoid process here, and you go a little laterally, and you can find a little squishy spot in there, and that's the fifth intercostal space, and that's where the apex of the heart is. So second intercostal space is the base, and the apex is down there at the fifth intercostal space. You find the nipple, and right in line with the nipple is pretty much where the apex should be. Okay, so with that landmark, you can find 4 different points of auscultation to listen to the valves. Now, the 2 lower points should be listening to the AV valves, and the 2 upper points are listening to the semilunar valves. Because the aorta arches to the left, okay, the one that's actually on the right is auscultated on the left. So over here is where you try to listen to the aortic semilunar valve. The pulmonary trunk comes out a little bit more to the right. So over here is where you try to listen to the pulmonic semilunar valve. And then down below, the right AV valve, the tricuspid valve, you listen to that just to the left of the sternal border in the fifth intercostal space. And then in line with the nipple in that fifth intercostal space is where you try to listen to the bicuspid valve. Okay? And like I said, I think it's in your book, it gives you a picture of that, and I'll put that on the chest of a torso model over there. I expect you to know those 4 points of auscultation. The stethoscopes that we have are not the greatest. They're new, but they're budget stethoscopes. So they have what's called a diaphragm on them. Okay, this is a diaphragm here. So there should be an alcohol pad in there. You can wipe the earpieces off, stick it in your ears, and just listen to your heartbeat. Okay, listen for the love dub. Usually you can hear it best kind of intermediate between where the nipple would be and the sternal border, down around the fifth or fourth intercostal space. That's where you're going to get a good strong signal. If you've got a thicker chest, you might need to move around a little bit closer to the sternal border where it's a little thinner to hear it. You put these in here and you just lightly tap on the diaphragm to make sure it's working. Don't hit it hard. It's going to be really, really loud if you do that. Don't ever take one of these and shout into it as a game or something that somebody else is listening. That can damage your eardrums. Don't do that, okay? Like I said, these are kind of budget stethoscopes, so it'll work fine for that. A nicer stethoscope, I think I have my instruction. A little bit better stethoscope, like you'll use in clinical practices. We'll have a rotating end on it. This is a teaching scope, so a student can use one set and the instructor can use the other set. It'll rotate, it'll turn around. So there's a little hole in there, and you turn that hole away from you. And so right now we'd be using the diaphragm, and I spin it around so the hole is facing towards the bell. The bell is used for listening sometimes to deep breathing sounds and to when you try to listen to the valves. It's the bell that you should use because it's made for listening to deeper sounds. Okay. I think there's a class next door. If there isn't a class next door, it's best to go into that room to try to listen to the valve sounds. Because if you're in here where everybody's just talking and shuffling papers, you can't hear them. It needs to be quiet. So if that room's empty, you can go do it. Or you can go sit out there in the hall if nobody's out there and try it. But if you try to do it next to somebody else, you just won't hear anything. You can hear the heartbeat, but you can't hear the valve sounds. The valve sounds really, when you listen to this, it's gonna sound like a that's what you hear, okay? And the valves sound the same, but a little bit more muted. If it doesn't sound sharp like that, then that's a murmur. Okay? It can be a little bit muted, it can be a little bit protracted. Again, I am no expert at this, right? I'm not a clinician, I never pretend to be. I go ask my wife about clinical stuff when it comes up in class, and she'll usually tell me. She'll teach me a few things, but you get good at this kind of stuff when you do it every day in rotations. Okay, so I'm not going to pretend to teach out all the nuances. Just my goal is if you go to your clinicals, you know how to put on a stethoscope, you know how to put on the sphygmomanometer, you know where these go, stuff like that. Okay, so that doesn't take very long to do that. Now the next thing we're going to do is learn how to do the auscultatory method of blood pressure determination. So for that you need a blood pressure cuff, which we have a couple. Oh, that's the women's cuff. Now, fancy name for this. What's the fancy name for a blood pressure cuff? A sphygmomanometer. Yeah. Somebody named that. Sphygmomanometer. Okay, so I definitely want you to know that that's This is an older style, so this has got the gauge on it, and you pump it up, and it'll put air into here, and that compresses the cuff. Now, all of our cuffs are small cuffs, so you've got a slightly larger arm, it's not going to read accurate. The cuffs are sized for the individual, so you should have a small, medium, and large cuff. Also, there's a screw button on the pump here, not a button, a screw valve. You got to turn that clockwise to close it so you can pump it up, and then you got to turn it the other way to let the air out when you're done. If you don't do that, the person's arm going to turn purple. Okay, so remember to let the air out. The LeMaster one, which is automated, that one I think it's a button you press. Now some of the really fancy versions of these, you really see them, they actually have a pump in them, and they'll pump up automatically. These don't, you still have to pump them up. But it has a relief valve there. Rather than turn this one, you press it to let the air out. For these, you turn the power on and you let it equilibrate. And it shows the numbers there, it's ready to go. So a couple things you have to make sure. You have to make sure that the valve is closed. Sometimes it sticks, so work it a couple of times to make sure it's closed. And then where this goes into the machine, sometimes that comes loose. So make sure that's fully seated in there. If it leaks, it won't regrate. And it's time to put the blood pressure cuff on. Now when you put the blood pressure cuff on, it's pretty simple. The little hose should always be pointing down the arm, not up, always pointing down. You can put it on either side. So when you put it on, it should come up above the antebrachial area, antecubital area, sorry, antecubital area. And these have a line on them. Sometimes they'll say right and left. These are small cuffs, so they're a little hard to get on. All right, that hose and line should be facing pretty much right down the midline of the arm. That's where your brachial artery is. And then, you want to pull it snug enough that you can fit your fingers under it comfortably. You don't want it too tight. You don't want if you pull it like that, it's already going to be reading high blood pressure because you pulled it too tight. So leave it a little bit loose so you can get 2 fingers under it usually, but it won't slide down. And then you're good to go. Okay. I'm moving around and sweating. So I'm going to tell myself that my blood pressure is probably going to be just a tad high. Okay? So don't yell at me if it's high. So turn this thing on. Be patient, let it calibrate. All right, read 0. Now the key to pumping this thing up is usually just slow, even, deep strokes. Don't go like that or it won't work. So we'll see. And then I got to shut up and not pump. (139/87). So that's a bit high. I'll put the criterion on the board. I think I mentioned it in class last time. If it's over 120 systolic, that's considered hypertensive. If it's over 80 diastolic, that's considered hypertensive. Most of the guidelines usually tell you if it's over 130 systolic, that's considered hypertension. Between 120 and 130 is pre-hypertensive. If diastolic is over 90, that's considered hypertensive. If it's between 80 and 90, that's pre-hypertensive. So those are the guidelines that I'd like you to use. So what is this, 135/87? All right, so I had that's hypertension. That's stage 1 hypertension. Now, I'm not too worried about that because, like I said, I've been moving around, and so obviously I'm not at rest. So when you take a blood pressure, your patient needs to be sitting down comfortably, not agitated, and the arm needs to be resting. You shouldn't be holding the arm. So if they have been moving around and they're really hyped up or whatever, you want to give them 5 minutes or something at least to calm down a little bit. If I were to sit down and take it again, probably 10 points lower, just resting a little bit. It'll also show your heart rate on here. We're also going to learn how to take a pulse. Now that's an easy one to use because it does it for you. This one, a little bit more difficult because you have to use a stethoscope in combination with it. This one has an arrow for left arm or right arm. And you start to feel a little special. Why? You're enjoying watching this? I can usually do it. Sheesh, not good. All right. So you get it on there like that.
You're a natural.
Dial reads through it.
No, my iPad fell.
Then you just stethoscope. So then they empty it here. You put the stethoscope down in the cubital fossa, just below where the sphygmomanometer is going to be sitting. And you got to hold it on there with a finger. So then you pump it up. Typically, I tell students pump it up to about 180, 200, somewhere around there. The blood pressure in the arm better not be that high. Right? So it should, once you go over 140, it should be good enough. But you go up to about 180. Now what I'm going to do now is I'm going to let the air out slowly but surely. Now right now, the pressure in the cuff is high enough that my brachial arteries collapse and there's no blood flowing into the lower part of my arm. So there won't be any sounds here. Now when I let the air out slowly, it's eventually going to drop below the systolic pressure, but it's going to be above the diastolic. When it's between those two, the vessel will collapse when the heart's not contracting and it will expand when the heart contracts. So I'll hear blood flow through it during systole when it's between the systolic and diastolic pressures. It will be turbulent flow because it'll be under pressure, so it'll make a sound. Remember, turbulent flow is noisy, so I'll be able to hear that. Those are called sounds of carotid cough sounds. And I'll hear that in this stethoscope, and it'll just sound like a little bit like a sound like that. When I first hear the sound, that's my systolic pressure. When I last hear the sound, that's my diastolic pressure. Okay? And then once I'm down below the diastolic pressure, let the rest of the air out of the cuff and let the person relax. Now mine's gonna be way high because I've been sitting here choking it off for several minutes. The technique though is how slow you let the air out of the cuff. If you go too fast, you won't get an accurate reading. If you go too slow, it takes too long and it makes the heart rate high. So I was already making sounds 125. So I got 130 over 85. No, 130 over 90. So the air out of the cup, take it off. And what I heard in there was just kind of a hum, 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 hum. This one sounds a little deeper than the red ones do. That's it. That's all there is to it. Pulse points, when you actually want to feel your pulse. Well, the easiest pulse point is called your radial pulse point. So that's on the thigh to your side of your thumb. You can feel the flexor ligaments right here. So there's a flexor hallucis longus and there's a flexor palmaris longus, those two tendons there. Between that, you should be able to palpate the radial artery. So put 2 fingers on there. Here it goes. Okay. And I usually count mine for 10 seconds and multiply by 6. Some people like to do 15 and multiply by 4. Don't do less than 10. Okay, so 60 beats per minute. I want you to know the guidelines for pulse, and that is that below 50 beats per minute is considered bradycardia. Above 100 beats per minute is considered tachycardia. Below 50 is considered brady. Above 100 is considered tachy. And a normal resting heart rate is considered 65 to 75 beats per minute.
So bradycardia?
Bradycardia is abnormally slow, and that's below 50. Abnormally high is called tachycardia, and that's above 100 beats per minute. Between 65 and 75 is a normal resting heart rate. Usually I give a slightly narrower range, 68 to 72 beats per minute.